The motor neuron signs are critical in helping you localize a neurological lesion. Upper motor neuron lesions are problems somewhere in the cortex or the spinal cord. Identifying features of upper motor neuron lesions are hyperreflexia, positive Babinski and Hoffman reflexes, and increased tone and spasticity. Lower motor neuron lesions are problems anywhere from the neuron exiting through the ventral root out to the neuromuscular junction. Characteristics of lower motor neuron lesions include muscle atrophy, fasciculations, decreased tone, and decreased reflexes. Both upper and lower motor neuron lesions present with weakness. A helpful way to remember these is that with upper motor neuron lesions, signs go up, such as increased reflexes, tone, and toes. With lower motor neuron lesions, things go down, such as reflexes and tones, as well as muscle mass. Lesions to different regions of the spinal cord can produce different symptoms, and being familiar with these can help you determine the location of the lesion. We're going to cover each one in depth in the next few slides. So what kind of vaccine is the polio vaccine? Well, there's the Salk vaccine, which is inactivated poliovirus from 3 strains. This is what's used now in the USA. And there's also the Sabin vaccine, which is a live attenuated vaccine, meaning that the poliovirus is able to infect and replicate in the gut, but has its neurological affinity removed. Early symptoms include fever, fatigue, headache, vomiting, stiffness in the neck, and pain in the limbs. About 1 in 200 cases leads to CNS involvement, causing destruction of the ventral horns. This leads to irreversible flaccid paralysis, which primarily affects the legs. Death can even ensue if the diaphragm becomes involved. Next, we have Werdnig-Hoffmann disease, which affects the same area as poliovirus, the ventral horns, and also leads to a flaccid paralysis. This is an autosomal recessive disease, so there is a 1 in 4 chance that future progeny will inherit the disease. It is both the most common and the most aggressive form of spinal muscular atrophy. Death usually occurs before the child turns 1 year old. Amyotrophic lateral sclerosis, which you may know as Lou Gehrig's disease, is classically described as a combined lower motor neuron and upper motor neuron deficit with preserved, meaning normal, cognitive and sensory function. The disease usually occurs in middle-aged men. It's thought to be caused by a defect in the superoxide dismutase 1 protein, which is involved in degrading free radicals. It is a progressive illness with death ensuing once the respiratory muscles become paralyzed. There is basically no treatment available. Riluzole is one drug that has been proven to lengthen survival in ALS by about 6 months. Essentially, ALS is not currently treatable. Here you see an image of tabes dorsalis. This is the sequela of tertiary syphilis. You get degeneration of the dorsal columns. So what can you predict will be impaired? Well, patients have impaired vibration and position sense. Other findings that you might notice with tertiary syphilis include Charcot's joints, neuropathic pain, and Argyll-Robertson pupils. These pupils are said to accommodate but not react to light. You may have heard them called prostitute's pupils. Now, unfortunately, the damage caused by tabes dorsalis cannot be reversed, and if it's left untreated, it can lead to paralysis, dementia, and also blindness. Here we have Friedreich's ataxia. It's caused by a trinucleotide repeat, GAA, in the gene encoding frataxin. What's another trinucleotide repeat disorder? Well, we had just discussed Huntington's disease. Now, like Huntington's, Friedreich's ataxia displays anticipation. However, Huntington's disease is autosomal dominant inherited, while Friedreich's is autosomal recessive. Cardinal symptoms of Friedreich's ataxia include progressive limb and gait ataxia, dysarthria, loss of joint position and vibration sense, and hyporeflexia. What do these patients most commonly die of? Well, the gene mutation also causes hypertrophic cardiomyopathy, which is the most common cause of death in these patients. They may have other bony deformities like pes cavus in the foot, scoliosis, or kyphoscoliosis that present early in childhood. The final spinal cord lesion we'll discuss is Brown-Sicard syndrome. This is a fancy name for a lesion that disrupts 1/2 of the spinal cord. So there's damage to all 3 columns, which is almost never clinically seen, but is a good teaching model to understand the tracts. Now first, we know about the corticospinal tract. Damage to this causes ipsilateral paralysis or motor weakness. Good. Second, the dorsal column is injured, thus patients will have impaired ipsilateral vibration and position sense. And lastly, we know the spinothalamic tract is damaged, and this will give us impaired contralateral pain and temperature sensation. Horner syndrome is quite interesting. It's caused by impairment of the sympathetic system to the face. It includes a classic triad of ptosis, anhidrosis, and meiosis. To understand all the causes of Horner's, you have to understand the anatomy of the sympathetic tract, and that's one reason why this shows up so often on the boards. The first neuron of the sympathetic pathway originates in the autonomic regulatory nuclei in the hypothalamus. The tract descends to T1 and T2 in the intermediolateral cell column. The preganglionic neurons exit at T1 and T2 and ascend up the vertebral chain to the superior cervical ganglion. The third neuron then travels with the carotid plexus along the internal carotid artery to reach the facial muscles. Thus, any lesion affecting the brainstem, such as an infarct, the thoracic spinal cord, such as trauma, the T1 and T2 nerve roots, for example a Pancoast tumor in the apex of the lung, something that affects the sympathetic chain, or even affecting the carotid plexus. Lesions in any of these various places can cause Horner syndrome, which again is ptosis, anhidrosis, and meiosis. Now we'll consider some very important dermatomes. A dermatome is an area of skin supplied by a single nerve. Usually when we say dermatome, we're referring to the sensory dermatome. The highest yield dermatomes for you to know about are C2, which is the distribution for the back of the head, T4, which is at the nipple on most bodies, T10 at the umbilicus, and then S2, 3, 4, which is the distribution of the genitourinary zones. The rest of them, of course, could be tested, so they're worth knowing about, but those are the main ones to focus on. Now I'll mention clinical reflexes. The biceps reflex tests the C5, C6 nerve root. Triceps tells you about C7. The patella tests the L4, and Achilles tests S1. So normal, when you say, quote, normal reflexes, means 2+ on both sides. Do you know what a positive Babinski's sign is and what it indicates? Well, positive Babinski reflex is an upgoing big toe when a blunt instrument is run along the bottom of the foot from heel to toe. In adults, this is a sign of an upper motor neuron lesion. Of course you know that it's normal during the first year of life. Primitive reflexes are those reflexes that we are born with but disappear in infancy. These are tested in newborns to help rule out brain damage. The moral reflex is what occurs when the baby thinks that he's being dropped. Baby will extend his limbs as if to grab onto something. This is normal until about 3 to 4 months. There are sucking and rooting reflexes. Babies just intrinsically know how to suck something if it is inserted into their mouth. Rooting refers to the baby turning to one side if the cheek or mouth is stroked trying to search for food. This reflex lasts until about 2 to 4 months of age. We also have palmar and plantar reflexes. When stroking the baby's hand, it will grasp your fingers tightly and can even sometimes pull themselves up. This disappears around 6 months of age. As we've mentioned, the Babinski reflex is an upgoing big toe with plantar stimulation, normal until about a year of age. And the Gallant reflex is less commonly tested. It involves lateral flexion of the lower body toward the side of the spine that you are stroking.